So, what are non-modifiable risk factors for cholecystitis? Say what? Being female? Yes. What else? Yes, aging, so being over 40, although that's, I hate to think of that as aging. Thanks, whoever said that. Okay, what else?
Sickle cell disease.
Say what?
Sickle cell disease.
Sickle cell disease actually is a risk factor. Pregnancy can
Is that
trigger. Say what?
I guess it's modifiable, I don't know.
That, well, once you're pregnant, not so much, and probably people are not going to not decide to have children because of the possibility that maybe they could have gallbladder disease. Because it doesn't happen to every pregnant woman, right? So, okay. All right. Crohn's disease is another one. And then, did you read anything about race or ethnic group? Caucasian. Yep, those three groups. Native American, Mexican American, or Caucasian. And then the other thing is family history. You know, the old 4Fs thing has been around forever. That's in your book. Female, 40, fat, and fertile. So, but I knew a couple of kids that had it when my kids were in high school. So they were really young, they were teenagers, and they were slender, otherwise healthy looking kids, but they had family history, so not fun. All right, so modifiable risk factors. Lifestyle, such as?
Like exercising versus being sedentary.
Right, and that's because if you're sedentary, then it might cause obesity and insulin resistance or diabetes, right?
Right.
The other thing is rapid weight loss or prolonged fasting can cause it. So we want to tell people to lose weight, but we want them not to do a crash diet. And everybody that's overweight wants to lose it fast, right? Me too. Elevated cholesterol is a risk factor, but so are cholesterol lowering drugs. Say what? Yeah, it's kind of a lose-lose situation, that's right. And then also women on hormone replacement therapy. And so they just kind of have to weigh the risk versus benefit of hormone replacement therapy, because hormone replacement therapy has been, I mean, now they're kind of trending towards not keeping women on it, but it's been thought to be protective against heart disease and osteoporosis. So there's some good things about it. Okay. So, for health promotion, somebody said lifestyle, like healthy diet, right? And exercise. Because with the healthy diet, if they're diabetic or have insulin resistance, then they can decrease that insulin resistance and also keep their blood sugar in normal range. Okay, did y'all read what's the best diagnostic test for gallbladder disease, for cholecystitis? It's, well, that's the treatment, but the, but ultrasound is the, that's the best initial diagnostic test. So they'll look for, they can see the fluid, they can see the stones in the gallbladder, and they can see if it's swollen, Another test they can do is called a HIDA scan, and I don't remember what that stands for. I think it's in your book, but what it is they inject IV some a radioactive tracer, and then they wait 20 minutes, and then they do a picture with their, I don't even know what their cameras are called, their nuclear scanners, and then they can look at the injection rate of bile into the bile duct, and if there's decreased flow, then that indicates gallbladder disease and obstruction. And obstruction can cause, if it's severe obstruction, they can develop jaundice. And so if they don't know why they've developed jaundice or why they have an obstruction, then they might do an ERCP, which is, let me see if I can do it, endoscopic retrograde cholangiopancreatography, which is why we always call it ERCP. That's done under sedation or general anesthesia because it's pretty painful. And they can, if there's a stone, they might be able to pull it out and crush it. They can sometimes do like a sphincterotomy or something like that if there's an obstruction like that. Okay, so pain relief. This is a very painful thing. They need opioid pain relief, and so that would be morphine or hydromorphone, which is also called, the generic name, the brand name is Dilaudid. Old sources may say meperidine is the best because they used to think that it caused less spasm of the sphincter novi. All opioids cause some spasm, and morphine and hydromorphone are more effective drugs. I don't really like Demerol much. I don't think it's as effective for pain, and it's been around for years. And it used to be the go-to thing if you weren't going to give morphine because those were the main two drugs. But the other thing is, like, kidney patients can't take it because it can cause seizures, and I've kind of read some things about maybe it was going to be taken off the market, but that hasn't happened yet. So I don't like it much, but you might still see it used. Okay, and the treatment is surgery, and this one is really cool because it's an actual surgery. It's the same guy. It's an actual surgery, and it shows you what the stones look like and everything. It's pretty cool. It's about 5 minutes.
Hello, I am Carl Lowe Jr. of Carolina Surgical, and I'm going to walk you through a live laparoscopic gallbladder surgery. Let's get started. We're going to make an incision at the umbilicus and then insert a trocar. We'll place our camera down the trocar so that we can see it as it goes into the abdomen. Once we're inside, we inflate the abdomen with carbon dioxide and then numb the skin so we can make our other 3 incisions. Insert another trocar through the abdominal wall.
It's kind of brutal, doesn't it?
A third. And our 4th and final trocar. These trocars allow us access into the abdomen so that we can place our instruments in and out of the abdomen to do the surgery. We grasp our gallbladder and retract it upward, and you can start to see some of those stones floating around inside the gallbladder. We're going to just gently tease away this fat here that's near the cystic duct. The cystic duct is the duct that connects the gallbladder to the main common bile duct. And we just gently tease away that fat until we can see the cystic duct starting to come into view. This is the most important part of the procedure. We want to be very careful and make sure that we clearly identify that cystic duct going into the gallbladder so that we're not confusing it for some other structure. Behind the cystic duct, we're going to start looking for our cystic artery. which supplies blood to the gallbladder.
See it pulsating?
And you can see this pulsatile vessel coming into view now. That is the cystic artery. Now that we have clearly identified the cystic artery and the cystic duct going to the gallbladder, we'll start clipping these structures so that we can divide them. We always like to clip first and then divide. We don't want to create any bleeding or bile leaking by cutting first and then clipping second. Now that they're clipped, we'll go ahead and divide the cystic duct and then the cystic artery. Now we're going to use an electric cautery device to dissect the gallbladder off of the liver. You can see this device does create some smoke, but it's nice because it will cauterize any bleeding points as we move along the gallbladder.
It cuts and cauterizes both. There are actually two settings for that. But if they cut with it, then it also cauterizes it.
And we just march our way all the way up the gallbladder, freeing it more and more off the liver. And there we have it. Now that the gallbladder has been detached from the liver, we place it in this bag.
Well, the bag went down the tube, the trocar, and then he's going to pull that through.
But before we do, we'll take one more look under the liver, just to make sure that there's nothing bleeding, and making sure our clips are in good position. We can see that our cystic duct is adequately clipped. There's nothing leaking from it. And you can see the cystic artery is also very well clipped, and there's no bleeding coming
Can they
from
not
there.
come loose though?
And there's also no bleeding from the liver. So now we're ready to take out the gallbladder.
Now watch this, he's gonna pull this through the hole. It just blows me away still.
We're just going to grab this string that's attached to our bag and pull the gallbladder out through this upper incision here.
That blow you away?
What is this called?
Just a bag.
And there it is.
That hole. Yeah.
We're just going to
Okay, so
cut this
now wait till you
gallbladder
see
open
these
so we can
stones.
see what these stones look like inside of it.
Can't watch. I'm not so
You can see some golden looking stones there.
Look at the size of this stone.
And that stone is about 1 centimeter or just shy of half an inch there.
That's huge. And this person had
Well,
multiples.
I hope you enjoyed the surgery. Thank you.
That was informative.
Okay, so you saw that surgery.